It is now my pleasure to turn the webcast over to Jan Hazel. Jan, the floor is yours.
Thank you, Brian. Welcome, everybody, to the fourth in the summer series of webinars on thyroid cancer that are sponsored by ThyCa. As you know, ThyCa has long been a sponsor of events, live events on the local, regional, and national level. So it's been really great to have this new venue of reaching out to more people far and wide, both now listening live and those who listen to the link in the future. So today we're going to talk about medullary thyroid cancer, the basics. And we're fortunate to be able to welcome Dr. Gagel, who is the head of the Division of Internal Medicine at M.D. Anderson. Dr. Gagel has been, although he's been an endocrinologist, and has been taking care of patients with medullary thyroid cancer for almost 40 years. Certainly it's a terrific record and is indicated by his publications and definitely by his generous donation of his time and knowledge and expertise to participating in other ThyCa events over many years. So before I turn the microphone over to Dr. Gagel, I wanted to remind you all to be sure to ask your questions. It's very helpful if you can keep them short and concise for the sake of time and ease of answering. I also want to remind you that anything that Dr. Gagel says, whether it's in the presentation or in the discussion of the questions, is really not intended to serve as medical advice, but rather a conveyance of medical information. So as always, be sure to consult your own physician for advice as it may pertain to you. So with that, I am going to turn this over to Dr. Gagel, and we will talk to you again in a few minutes. Thank you. So I think Dr. Gagel needs to unmute his phone.
I'm sorry. Good morning, everyone. I'm Bob Gagel. I'm calling in from Houston, Texas at the M.D. Anderson Cancer Center, and it's a pleasure to try to share with you today some of what I've learned about this disease over the last 40 years since I first became involved. And so I'm going to begin with the first slide, which is actually a Father's Day card from my daughter. And as many of you know, medullary thyroid carcinoma occurs in two types. The first is a genetic form, which we call Sippel syndrome or multiple endocrine neoplasia type 2. The second being sporadic medullary thyroid carcinoma, which accounts for about 75% of all medullary carcinoma and is caused by the same mechanisms but doesn't run in families. And that's an important point. But this slide from my daughter, she wanted to let me know that she had a few imperfections, but also wanted to point out that those must be from her mother's side of the family. And so this is a reminder that multiple endocrine neoplasia type 2 and medullary thyroid carcinoma can be a genetic disease, and we'll come back to that because it's important when there is a lack of clarity about this to provide clarity and to understand this. So medullary thyroid carcinoma is a malignant neoplasm of the thyroid gland. It is derived from a subset of cells, which we call the C cells or calcitonin producing cells of the thyroid gland. They represent less than 1% of all the cells. The histologic features of medullary thyroid carcinoma include a unique configuration of the cells when we look at it under the microscope that resembles a nesting or sort of nest of neuroendocrine cells with a proteinaceous or amyloid stroma, and I'll show you a few slides of that in a minute. The tumor can also be calcified, and in fact what occurs there is that the amyloid can attract calcium, and calcium is deposited on the amyloid fibrils or protein, and that leads to calcification, which we can actually see on an X-ray. The tumor has several unique tumor markers that include the hormone calcitonin. This is a calcium-regulating hormone, and since the cancer is derived from the C cells or calcitonin-producing cells, calcitonin can be produced in large quantities. There is a second tumor marker called carcinoembryonic antigen, or CEA for short, which is also a tumor marker, and I'll show you some examples. So this figure shows the nesting, and if you step back from the image and look at it, what you see are nests of tumor cells that sort of serve in a cluster. This is a characteristic appearance of what we call a neuroendocrine tumor, and is very different from the other types of thyroid cancer. So it doesn't take much time for a pathologist to separate this from the more common papillary or follicular thyroid cancer. The next slide shows the presence of amyloid. So you can see the little cells, the very small round dots, which are nuclei of the cells, and then surrounding it the white cytoplasm. But in between those clusters of cells is a proteinaceous or protein-like pink material, which if we stained it would stain for a protein type called amyloid. It actually is the protein calcitonin, or its protein products, which develop into a structure that sort of folds back on itself and creates this amyloid-like structure. It looks a bit like a glob. This slide just makes the point that medullary thyroid carcinoma, when it occurs either in the neck or in the liver, as in this particular case, if you look at the image on the left-hand side of your screen, you will see that there are spicules of calcium up in the area where the liver sits. And in fact, you can see where the liver is from this image. And if you look at the CT scan, or a slice from a CT scan on the right, you see the clustering of calcium within the liver. This is a patient with widespread metastatic medullary thyroid carcinoma, long-standing, and therefore there is lots of calcification within the liver. These are calcified foci of medullary thyroid carcinoma. So there are three phases in our understanding of medullary thyroid carcinoma, and I'm not old enough to go back. Well, I am old enough. I was a sophomore in high school when medullary thyroid carcinoma was first described in the late 50s and early 60s. And so the understanding of this tumor has taken place entirely during my life and not before. So it was separated out from other types of thyroid carcinoma actually in 1959, but multiple endocrine neoplasia was first described by Sippel in 1961 when I was a sophomore in high school. We then went through a period which we call the prospective screening period from 1973 to 1993, and then from 1993, when we discovered the causative gene for this disorder, we call it the genetic phase. And on the next slide is shown the history of medullary thyroid carcinoma, and importantly, this the entire history of this syndrome and medullary thyroid carcinoma has taken place in the last 60 years. While there was the recognition of certain of the syndromes, the genetic syndromes prior to that time, nobody had put together that it was transmitted in families, and no one had separated medullary carcinoma from the other types of thyroid cancer. So this is a relatively short history. So let's talk about the type of cells in the thyroid gland. This slide shows the distribution of C cells within the thyroid gland. And what you see on first glance is that in each lobe there is a concentration shown on the slices pulled out to either side of white dots, or red dots actually, which represent the distribution of C cells within the thyroid gland. And you can see that the greatest concentration of those C cells actually occurs at in the junction of the upper third and lower two-thirds of each lobe. I think I may have that on, yes, on the next animation. And in hereditary medullary thyroid carcinoma, that's generally where we see a tumor. The next slide shows a histologic section, or something that you look at under the microscope. So you magnify this by anywhere from 30 to 100-fold. And what you see are the organization of the thyroid, and the thyroid follicles are the circles that are encompassed by cells that contain blue nuclei. And in between those follicles, which contain the protein that, when broken down, produces thyroid hormone, you see these red cells which are stained for calcitonin. And these are the C cells. And normally there are one or two of these cells in a section. This happened to come from a young girl who had who had a predisposition for hereditary medullary carcinoma, and you can already see that there is an increase in the number of cells. So I'm just showing you here the thyroid follicular cells in blue and the C cells in red, which produce calcitonin. Now let's blow one of those cells up, and you can see that it stains red for calcitonin. The cause of most medullary thyroid carcinoma is a change in the DNA structure for a particular gene called RET, and we're going to talk more about it, but I wanted to show you where this protein, or this gene which then encodes a protein, sits. So you see a nucleus, which is the location for the DNA, and then you see the red, which is called the cytoplasm, which contains a variety of different proteins and cellular material. And then in the cell membrane itself, that is the outer perimeter of the cell, this protein called RET sits, and it is a switch. It turns on several aspects of the cell, including the production of calcitonin. It prevents the cell from dying, and it stimulates it to grow when another protein called GDNF, which is slowly migrating in, binds to the receptor and activates the receptor, causing the cell to turn on certain functions. So when we talk about RET, while we're going to be talking about the bad things that RET does, in fact, RET is a normal and necessary player in the normal function of the C cell. And the C cell, the hormone calcitonin, has important functions in regulation of bone and a number of other functions. So it's a normal cell. We can live without it, in part because it's produced in other places within the body, but it serves an important physiologic or function in normal normal life. So what happens to these cells? Well, in a condition which we call C-cell hyperplasia. So these sets of slides are taken from an individual who has hereditary medullary thyroid carcinoma, and taken from different parts of the thyroid, and in fact they're not all from the same person. But it shows the progression that occurs in someone who has a mutation of the RET gene as he or she goes through life. And And what you see in this slide is just an increase in the number of C cells. There's no evidence of a tumor. As another few years pass, what you see is that these cells continue to grow, and a condition which we call nodular C-cell hyperplasia develops. And then after another 5 to maybe as long as 10 years, we see a much angrier looking lesion which we call microscopic medullary thyroid carcinoma. So there's a natural progression of this, and the important thing for you to understand is that RET, or that cell surface receptor, is the on switch that stimulates the cell, but there are other things going wrong with the cell that turn it into a cancer. So this is if one had hereditary medullary thyroid carcinoma, this slide shows what it looks like. And you can see that there is a tumor in the upper, at the junction of the upper 1/3 of the left lobe and the lower 2/3, sitting in exactly that place where I showed you earlier that the greatest number of C cells sit. Now it doesn't, you see a similar lesion on the right lobe, or what is on the left side of the screen, and if you look carefully, you see that down in the lower right lobe there's another focus, and in the left upper lobe there's another white focus of medullary carcinoma. So this is what we would say multifocal disease, and of course if you're going to treat this successfully, one needs to take out the entire thyroid gland. Now, because this disease runs in families, we were able to use this feature starting in about 1981 to map the causative gene. And from 1981 through 1987, the locus of the gene was narrowed to include a specific chromosome. There are many chromosomes. This happens to be the 10th chromosome, and it was localized to the middle of the chromosome. Over the next decade, less than a decade, 6 years, it was narrowed down to the RET gene, which is this receptor that sits at the cell surface. And the mutations are many, or the types of mutations. So this is the structure of the gene. It contains about 21 exons, those being the boxes, the rectangles that you see that are in light blue, and the mutations that cause medullary thyroid carcinoma and multiple endocrine neoplasia occur mainly in exons 10 through 16. And there are single amino acid changes that modify the protein, change the structure, and turn this gene or this protein on. And think of a mutation as an on switch, that the gene and the protein, which are normally highly regulated, lose their regulation and just get put on permanently. And we can detect these mutations relatively easily by doing DNA sequencing protocols and do routinely in this disease. While we know the mutations in about 99%, there are still a few families out there for whom we have not found mutations. As the years go by, there are fewer and fewer of those as sequencing becomes less expensive and easier to do. And at this point in time, there are only a handful of such families in the world where we do not know the specific cause. So in classic multiple endocrine neoplasia type 2A, you see the same image that I just showed you of medullary carcinoma, but there are also tumors of the adrenal gland. And I bring this up for those of you who may belong to one of these kindreds, and I noted a few such individuals, that it's important for you not only to be checked for medullary carcinoma, but these adrenal tumors, which are generally benign, but can cause problems because they produce adrenaline. And so it's something that if you fit into one of the families with multiple endocrine neoplasia type 2A, that you should be very concerned about this and be tested for it, because too much adrenaline can be a bad thing. It can cause high blood pressure, and it can cause irregularities of the heart and stoppage of the heart if they grow to be large. If they're taken care of appropriately, there really are no problems, but they may have to be surgically removed. So if we look, the other thing that's interesting about medullary thyroid carcinoma in the context of multiple endocrine neoplasia type 2A is that if we know the mutation and the specific nature of the mutation, we can tell you what manifestations of this syndrome you might have. And I'm going to very quickly go through those because I wanted to spend more time talking about medullary carcinoma and get your questions. But the important point is that we can tell you something about what your future is likely to be based on the presence of a mutation. So the first is classic Sippel syndrome or multiple endocrine neoplasia type 2, where there is most commonly a 634, which is sitting on the outside of the cell membrane, but it may be associated with some other mutations, which I've shown on this slide. The second type of multiple endocrine neoplasia type 2 is 2B, and that's a very distinctive phenotype in which a child born with this disorder has characteristics shown on the left side with thickened lips, and in this particular young man's case, you can see a lump in his neck, which represents a medullary thyroid carcinoma. He also has neuromas or neurologic tumors that occur at the distal end of the tongue and then throughout the gastrointestinal tract, and can be problematic by their size. Some patients with this disorder also have what we call Marfan's-like features with long, thin fingers, and if you see this lady on the right, both she and her son are affected. She has very long legs, is quite tall, has very long arms, and this is an alteration of growth such that her lower body is much longer than her upper body, and so that's another feature. There are a couple of mutations that, again, they occur on the inside of this protein. So the RET receptor spans the cell membrane. Some of it is outside, some of it's inside. For this particular syndrome, all of the mutations that have been described occur on the inside of the cell membrane. There's a third variant, which is MEN2A with cutaneous lichen amyloidosis, and a very small number of patients will get this rather striking skin lesion over their upper back. It tends to be very itchy. It's clear that the skin lesion is caused by repetitive scratching, and it has also been found only with the 634 mutation. There's another variant called MEN2A where there is a condition that's more commonly seen in children called Hirschsprung. In fact, it's the most common cause of intestinal obstruction in children, and individuals with the three mutations I've shown on this slide can get problems with their GI tract like children with Hirschsprung's disease. So a question, when we first see a patient with medullary thyroid carcinoma, we don't know whether this runs in the family, that it's genetic, or whether it occurred sporadically, that it occurred only in the affected individual only as a single mutation that occurred within the individual's thyroid gland. And the reason this is important is that children of an individual with the hereditary version need to be tested. If we test the children and remove their thyroid at an early age, we can cure them. And so it is important for any patient with medullary thyroid carcinoma to answer the question, is this a germline mutation, i.e. one that's present in every cell and can be passed on in the sperm or eggs to children, or is this a sporadic case that is only going to affect the individual who has the medullary carcinoma? And so to determine how common this was, we and others studied this question over the years, and we've learned that medullary carcinoma, whether it's hereditary or sporadic, can be multifocal. We also learned that family history is very unreliable, and that there can be multiple sites within the thyroid gland that can be involved in both hereditary and non-hereditary. And in our studies, we found that roughly 6% of individuals who had been classified as having sporadic medullary thyroid carcinoma in fact had the hereditary variety, and so their children were at risk. If one looks broadly across many different centers here and in Europe, one sees that somewhere in the range of 6.8%, or about, 6.8% of individuals, in fact, who are considered to have sporadic medullary thyroid carcinoma turn out to have hereditary medullary carcinoma. And the important thing there is that there's a multiplier effect. If you look at these families, a single individual can lead to the discovery of medullary thyroid carcinoma in other family members, and particularly if they're young, in the third generation. If you go from top to bottom here, all of those children were curable, and in fact were cured by early intervention. So it's important to know that, and it's important for you, if you have so-called sporadic medullary thyroid carcinoma, to insist that your physician do a RET analysis on you to determine whether this could be hereditary. So let's leave hereditary medullary carcinoma and move and talk a little bit about sporadic medullary carcinoma, and then talk about the general behavior of medullary thyroid carcinoma. So sporadic medullary carcinoma accounts for approximately 75% of all medullary carcinoma. And unlike the hereditary disease where there's multiple foci within the thyroid gland, sporadic medullary thyroid carcinoma usually arises from a single cell within the single C cell within the thyroid, where there develops a mutation or a DNA abnormality, commonly of the RET gene. We know that somewhere between 50 and 60% of sporadic medullary carcinomas will in fact have a RET mutation. We're still looking for the causes for the other 40% or so, and to date we have several candidate genes, and it's probably going to turn out that there will be several different gene mutations causing this. And a high percentage of those with RET mutations turn out to have a specific mutation in codon 918. That is the same mutation that, when present in the germline, causes multiple endocrine neoplasia type 2B. And it turns out that that is important, as we'll come to in a few minutes. Now, how do we treat medullary carcinoma? Or perhaps we should talk a little bit about how it's diagnosed. Most commonly, medullary thyroid carcinoma comes to attention in one of a couple of ways. First, as a thyroid nodule, either a physician notes a bump in the thyroid gland, or a patient notes a lump in the thyroid gland while he's shaving or she's putting on makeup, and brings it to the attention of their physician. At that point, a fine needle aspirate, or sticking a tiny little needle into the neck to make the diagnosis, can be performed, and from that it's possible to make a firm diagnosis of medullary thyroid carcinoma versus either a benign nodule or a different type of thyroid carcinoma. Now, if in the other way that individuals can present is with the presence of a lymph node in the neck, and it's very common, in fact, in most individuals who have a medullary carcinoma that is greater than 1 centimeter in size, something the size of your big thumb, or not your big thumb, but your thumb, there will be spread of the tumor to local lymph nodes. And so sometimes there can be asymmetric growth in which the lymph nodes actually grow to a larger size than the primary tumor. And so one could also present that way. A third way that an individual might present is with diarrhea. And usually this indicates that there is some sizable amount of tumor, and that the tumor has spread to the liver, although not 100% of the time. And so, in some cases, I would say 1 or 2 in 100, that's how medullary carcinoma first comes to attention as the diarrhea or cause of the diarrhea is being evaluated. So I'm sorry, I jumped ahead there too quickly. So the treatment for all medullary thyroid carcinoma is a total thyroidectomy. And in fact, if an individual has a hemithyroidectomy, or half of the thyroid removed, we routinely recommend that a completion thyroidectomy be performed. And I won't go into all the reasons for that, but we're pretty dogmatic about that. It's important to do a thyroidectomy even if there is the presence of distant metastasis, because what we try to do is protect the airway, or the trachea, which runs right behind the thyroid gland. If one doesn't remove the tumor, it can sometimes grow into the trachea, and that causes all kinds of problems. We would also, if there are enlarged lymph nodes, we would also do either a unilateral, one-sided lymph node dissection, or do a bilateral lymph node dissection. And perhaps during the question and answer period we can get into some of the indications and why we would do one or both, but I'm not going to take the time now. So the other thing that we do once we take the tumor out is to do a RET analysis on the tumor itself. So if we find out that the individual doesn't have a germline mutation, meaning a RET mutation in their peripheral blood, then we would look at the tumor itself for the presence of a RET mutation, particularly a 918 mutation. And we do that because it has prognostic significance. This is data or a figure taken from a paper from Friedhelm Rau's group in Heidelberg, showing the difference in outcome between an individual with a 918 mutation, which is the curve that I'm putting the red line on, versus someone who has a normal sequence at that location. And what you can see is the likelihood of dying or having extensive spread of the tumor is much, much greater in the individual that has a 918 mutation. We think that's important to know because it would impact on how we would treat the tumor and how aggressively we would pursue therapy of the tumor. There's also some evidence, which we may have time to get into later, that patients with 918 mutations respond better to the current therapy for these tumors. So we like to know that, and as a result, in our institution, we do this routinely on every patient, at the present time, on every patient with a 918 mutation. The other point that I would like to make is shown on this slide, and that is that there are several indicators of survival and how patients will do. And this slide shows a standard survival curve. That is, on the abscissa, or the y-axis, is the percentage of patients with the disease who are alive at a particular year from the time of diagnosis, which is shown on the x-axis, or the abscissa. And basically the point that I would make is that if the disease is localized, then the survival at 10 years is going to be greater than 90% in general. If there is spread of the tumor to regional, meaning to local lymph nodes, or extension into regional, meaning in the area of the neck, soft tissue or muscle, then the survival is going to fall at 10 years to about 75%. If there is spread distantly, mainly to the liver or lung or bone, then you can see that survival, even at 5 years, drops below 50%. So these are significant differences, but do help us make decisions about what we should be doing in the way of treatment. Another indicator of how a patient is doing is the rate of change of the two tumor markers. And I mentioned earlier that medullary carcinoma produces calcitonin and also CEA. And it's important, particularly for those of you who have been recently diagnosed with medullary carcinoma, that you not hang on each individual calcitonin measurement. Perhaps the most important point that I'm making on this slide is that the calcitonin and the CEA measurements, which are plotted here over a number of years — I'm sorry, the text may be small on your screen, but this is plotted over a number of years, and what you can see is the measurement-to-measurement variability of calcitonin is huge. It can be as much as 2 to 3-fold. So you shouldn't be worried if your calcitonin value goes up or if it goes down from visit to visit, because that's to be expected, and there are good reasons for that. It's a peptide that is secreted stored in the cell in a granule, and then is secreted as a bolus, in a lot secreted at one time. So from 10-minute period to 10-minute period, you can have as much as a 2 to 3-fold difference in the calcitonin level, even though nothing has changed. But it is useful if you trend this over a number of years to determine the rate of the growth of the tumor. And on the next slide is shown what happens in terms of survival for patients who have a calcitonin doubling time of greater than 1 year, meaning that in 1 year, on the average over a number of years, that the rate of increase of the calcitonin is greater than 1 year. That is, the doubling of the calcitonin takes more than 1 year. Those patients on average do much better than those who have a doubling time of less than 1 year, which is shown in red. And so, again, that's important information for us to know to make decisions about whether we should treat a particular patient, or maybe we should just watch if the doubling time is very slow. And what you can see from the left figure is that if the doubling time is very slow, that you may live with this tumor but never die from the tumor. So this is one way that we get at that question. Which should we treat, which should we watch? Okay, I'm just going to say a few words about therapy, and given the time restrictions and the fact that I'm sure that you have some questions, I'm going to talk only about the approved therapy. I will mention the unapproved therapies in clinical trials, but only if there are no questions will we go back to the slide set and talk about them in detail. So we've already talked about the RET proto-oncogene, and on this particular figure, this is a cartoon of a cell, and what you see are several receptors that are probably involved, or not probably, are involved in the development of medullary thyroid carcinoma. The most important, clearly, is the RET receptor system, but there's an epidermal growth factor, a receptor called c-MET, and several vascular endothelial growth factor receptors that can also be activated in medullary carcinoma. So current efforts are focused predominantly on these 4 receptor systems and a few of the intracellular signaling proteins that are shown on this slide. And that's with good reason. The drugs that target these receptor systems are the ones that have been shown to have efficacy. And so while when we started out looking for drugs that would work in medullary carcinoma, we focused our attention on RET because it was what was mutated or changed or abnormal in medullary carcinoma. But what we discovered was that drugs that target these others, as well as RET, also seem to have activity. So we've opened our minds a bit and have broadened the search. This slide shows several of the current drugs that are either in clinical trials or approved. Now, vandetanib was just approved for treatment of progressive and metastatic medullary carcinoma about 2 or 3 months ago, following a large international clinical trial which showed efficacy. And I'm going to tell you a bit about that, so I'll not tell you more right now. But there are several other drugs with activity, and our current thinking in terms of the prioritization of activity is that XL184 and E7080 probably have the greatest activity. Sunitinib would probably fall next, followed by sorafenib, and the least amount of activity, and probably it's been dropped from development, is a drug called motesinib. And so all of these, with the exception of vandetanib, which is approved and can be prescribed by an endocrinologist and oncologist, all of these others are in clinical trials, and 2 of them are available for other cancers and are approved for other cancers and are available and have been used to treat medullary carcinoma. But vandetanib is the only drug that is actually approved specifically for medullary carcinoma. vandetanib, or its other name is ZD6474, is shown, and it's a chemical structure that looks a little bit like adenosine triphosphate, and what it does is sits in the binding spot for adenosine triphosphate and prevents it from binding to the RET receptor, and therefore prevents the addition of phosphate groups to the RET receptor and other downstream genes. Oops. And here you can see that RET has several targets that vandetanib, or ZD6474, has several targets, including RET, EGFR, and VEGFR. And so it is particularly effective against RET and the vascular endothelial growth factor receptor family. And we were able to convince AstraZeneca to let us do a clinical trial. This was initiated by Dr. Sam Wells at Duke, and we should give him full credit for convincing AstraZeneca to try this, because they were really not interested initially. And in the very first patient he treated, you can see in this image that the large lesion, and I'll just circle it here, shown here on the right-hand figure, has decreased in size rather dramatically in a 3-month period of time. This has never been seen before. Prior to this study, had never been seen before in medullary thyroid carcinoma. So, and as we collected more information, as more of us joined this study and subsequently participated in the phase 3, we saw many examples of patients who had lesions in their liver, this shown in this slide, and basically the treatment with vandetanib punched a hole in the lesion and made it die. You can see that blown up on this image where you can barely see it, and when treated with vandetanib, you see it's lost its blood flow and turned into a dead and necrotic tumor. So this led to a phase 3 trial, which is the last type, a type of trial that is required for the FDA to prove a drug. And this was a randomized placebo-controlled trial in which 2 out of every 3 patients received active drug, 1 received the placebo. So you have something to compare it to. There was, of course, a crossover design so that if you were in the placebo arm and didn't get active drug, you could cross over if you wished to receive active drug when the tumor had grown or at the end of the study. And we had a number of such patients who did that. This shows the important data set, which is progression-free survival, and you can see that for the vandetanib group shown in the red, that the progression-free survival, that is the number of patients who did not have progression of their disease, was much better, was much longer than in the patients who received the placebo. It was strikingly different. And in fact, the treatment group never reached what we call the 50% point. So we actually don't have the estimate for progression-free survival is around 11 months, but until more people have progression on drug, we actually won't know what the progression-free survival on drug is. It'll certainly be more than the 11 months. We're quite sure of that. And this is what we call a waterfall plot, which quantitates the amount of shrinkage of the tumor. And the red shows the vandetanib, and for the placebo, you can see that there's much less shrinkage of the tumor. So as a result of this, the summary statement is that there was significant improvement in progression-free survival with a 54% reduction in risk of progression or death. The progression-free survival was prolonged by approximately 11 months, but that will be longer almost certainly. There was benefit across all predefined subgroups of patients and compelling evidence of anti-tumor activity with a response rate of approximately 45%. And the median duration of response for vendetinib was not reached at 24 months, which was when the study ended. So quite effective. There are some side effects of this and the other drugs. For vendetinib, the most important one is that it can cause electrical abnormalities of the heart that has to be watched for. And what I'm going to do now is to stop and take questions, and I don't think that time will permit us to get to the other therapies, but I know that Dr. Ball in his last presentation covered some of this. And so I think you probably, or most of you had probably heard that. So let me stop at this point and take any questions.
Well, thank you very, very much. And I want to remind everybody that they can go back and watch this again if you've missed something or if you need to get a little bit more background information for better understanding. So with that, I'm going to ask the first question, which is somebody that was diagnosed sporadic several years ago, say maybe 5 to 10, 15 years ago, and they were tested negative for the RET gene in their blood, but they have children, and so they're obviously concerned that perhaps when they were tested there was not all the information that we have now. Should they be retested, or what would you recommend for that?
Yeah, I would. Well, there are a couple of answers to that. I would ask to be retested, and 15 years ago, there were a number of mutations that had not been identified. That was relatively soon after the discovery of the RET gene involvement in hereditary medullary thyroid carcinoma, and we didn't know all the mutations at that point in time. So for that reason alone, I would go back and test. It's better to be safe than sorry.
Thank you. So talking about calcitonin, I see a lot of going back and forth about how the serum sample should be preserved or treated, and what are should you be fasting? What are the conditions, the ideal conditions for when people have their calcitonin tested?
Yeah, so we do it in the fasting state, and the reason for that is very simple. When you eat a meal, the level of gastrin being a hormone that stimulates acid production by the stomach, but coincidentally it also stimulates calcitonin release. So if you have a blood drawn after you've eaten a meal, there will be a stimulus, a normal physiologic stimulus to calcitonin release, and we would expect that your calcitonin level would be higher. So to make sure that you're comparing apples to apples, we encourage patients to have the measurement done in the fasting state.
Thank you. So that's a perfect lead-in for the next question, which is how do proton pump inhibitors, and for those who don't know, those would be something like Prilosec that you would take for GERD or dyspepsia. How do they affect calcitonin, and how should that be taken into account when a patient is tracking their calcitonin?
Yeah, so I generally encourage patients on proton pump inhibitors, Prilosec, Pepcid, Nexium, there are several others, to get the blood drawn before they take their morning pill. And again, the reason for that is that there is a feedback relationship between gastric acid secretion and gastrin production. And so if you take the pill that blocks acid production in the stomach, what you get is a feedback effect so that gastrin goes to a higher level. Gastrin stimulates calcitonin release. So it will almost certainly affect the level of calcitonin in the blood in a stimulatory way.
And just to clarify that, as you said in your presentation, this is really just a stimulation of the release of calcitonin and doesn't really reflect an increase in the size of the tumor, right?
That's correct.
So another question is there any type of other type of thyroid cancer that can turn into medullary?
Let me say no. There are rare examples of what is called what is thought to be a fusion. So you could imagine a situation where you have, if you think back to the image that I showed you of the thyroid showing that the thyroid follicular cells that produce thyroid hormones sit immediately adjacent to the thyroid C cells. If you could imagine a situation where you have a cancer of a thyroid follicular cell, and by chance one of those cancer cells fuses with a normal C cell, and that does occur in nature. In fact, we use it to produce antibodies by fusing cells that have unique characteristics with other cells that have different characteristics and creating what we call a hybrid cell. That does occur, and every now and then, I'm going to say at MD Anderson about once every 2 to 5 years, we will see a patient with a cancer that has some features of papillary or follicular thyroid carcinoma from the thyroid follicular cell, and also some features of medullary thyroid carcinoma. But it's a very rare occurrence, and it doesn't happen very often. But it has been described. We see it, and it's rare.
Oh, here's a great question. So this is a newly diagnosed person with medullary thyroid carcinoma. And they've got a CEA that's definitely increased, elevated, and calcitonin. So they're newly diagnosed here in August, but they're not scheduled for surgery until late October. Should they be concerned about something happening between now and then?
Probably not. It is any time you have a cancer, there is, of course, a concern that that cancer will grow and spread between the time of diagnosis and the time of surgery. And in medullary, as you noted from the slides that I showed you earlier, there are tumors that can grow relatively quickly, but the good news is those are rare, and the average medullary carcinoma is going to grow slowly. So in general, we would not wait for 3 months to do a surgical procedure just because there's no compelling reason to wait. But unless you fit into that category of patients where this is growing very quickly, the probability is you will suffer no harm by a delayed thyroidectomy. Our thought process would be, why are we waiting? There's no good reason to wait as far as we can see.
So I'm going to just step in and ask you this question. Is it worth waiting a few weeks to get in to see one particular surgeon, or is it more important than to go quickly and just choose the surgeon who can get to you first? And I'm talking about people who aren't fortunate enough to have gone to MD Anderson for their first visit.
Yeah, I think it's probably, this is a disease that the average surgeon in the community might see every 3 to 5 years. A head and neck surgeon may only treat one a year in the community. So there are surgeons in the country mainly at referral centers, Mayo Clinic, Yale, Washington University, our institution, who do a large volume of this and have a sense for the natural behavior of the tumor. The way I would deal with this is very simple, that if, and I would ask the question, how many cases of medullary carcinoma have you seen in the last year? If the answer is 0, I would probably look for someone else in your community who has more experience. I'll just say it that way, because there are some unique features of this disease, and there is a right way to do it, and there's a wrong way to do it, and there is the belief, and let me say the evidence for that is not completely perfect, but there is the belief that the skill level does matter for this disease.
Thank you. And have you seen any, this is a kind of a controversial topic, but have you seen any partial or full responses from radiation treatments, and particularly including something such as the CyberKnife radiation?
Yeah, radiation, the data on radiation, the carefully done studies are very few. But what we can say from the overall experience is that radiation is effective for suppressing local growth of the tumor. It's also fair to say that there have been very few or no cures with radiation alone. It is, in general, when we use it, and we use it less now than we used to, we use it to suppress the regrowth of disease in the neck, particularly in a patient who's had multiple surgical procedures, and there just isn't much more we can do surgically. But these days we're equally likely to consider a therapy such as bendetinib in that situation.
The next question is regarding somatic mutations. So you talked about how now it's routine for you to do a mutation analysis on the tumor when it's removed during a thyroidectomy. So, and then you went on to say that current therapies seem to respond better in patients who have a 918 mutation as compared to those who did not. Can you comment? You said you might comment on that more later.
Yeah, so in the bendetinib data set, I didn't show that data, but what is shown very clearly is that patients who had a codon 918 RET mutation had a better response than those who did not. And so there's now good reason to do this analysis on the tumor, because it provides us both with some prognostic information about what the individual patient is likely to experience in the coming years, and it also points us to a therapy. Now, granted, bendetinib is the only approved therapy for medullary thyroid carcinoma at the present time, so we're probably going to use it in any patient with progressive or metastatic disease based on that alone, but it provides us with some additional information.
Great, thank you very much. Well, we have a few more questions that we will try to we will bring together into a document to see if perhaps they can be addressed at a later time. But we thank you very much for your time. Before everybody logs off, I want to say to be sure to check ThyCa.org website to look at the schedule for the remaining webinars of the summer series, and to also look for the information on the upcoming conference in Los Angeles in October. That's the annual national conference. And I believe that with that, I would like to say thank you again to everybody and hope to see you in Los Angeles. Thank you.
Let me add my thanks for your attendance, and we hope that this was informative.